I'm an associate professor at the University of Stavanger, where I'm based in SHARE, the Center for Resilience in Healthcare. And I'll say a little bit about that as well. And I think that the main reason why I've been invited to give this talk today is that I was so fortunate to be able to do my PhD at the University of Sheffield with Dr. Claire Relton as my lead supervisor and Professor John Nicol as a co-supervisor. So I think that most of you are probably very well familiar with the article that they published in the British Medical Journal in 2010, which first introduced this type of trial design. And being also a PhD student at the University of Sheffield and part of this project, I had the also great opportunity then to recruit participants through what was then called the South Yorkshire Cohort, which is now the Yorkshire Health Study. And today, as I said, I'm based since 2016. I'm based at SHARE, the Center for Resilience in Healthcare, which is the largest research center in Norway, focusing on quality and patient safety in healthcare services. We have about 70 researchers who are carrying out their research in various clinical fields in both primary and secondary care and transitional care as well. And my research focus here is in mental health in youth, in adolescents and youth. Yeah. So I'll get back to that towards the end of this presentation to just share a little bit about our plans for the future. So the idea for today is to cover 4 points: approaches to analysis, case analysis example, which will be quite concrete, and also towards the end I'll also talk a little bit about comparison of compliers and non-compliers and questionnaire responders and non-responders. So the approaches to analysis, I think that what I will be sharing here, most of this will be, you'll be quite familiar with this, but it's kind of to try to place case analysis, which I think are quite useful in twixt trials, maybe even absolutely necessary. But yeah, it will put the case analysis within the context. So for some reason I'm seeing, okay, trying to, can't see my whole screen. Okay, we'll start out with the intention to treat analysis. You see the abbreviations at the bottom of the screen here. And if we think about a hypothetical trial where we include 400 participants, and we then do an equal group randomization process with 200 in an intervention group A, these participants will then receive a new intervention to be tested in addition to the treatment they're already using, let's say, for example, for patients with dementia. And this will be compared to control group participants who are then using treatment as usual alone. And there we go. So the comparison here is simply the intervention versus the control group. And the analysis is carried out as randomized. So if all participants comply, then we will get an estimate of the effectiveness of the intervention received. However, as I'm sure you're aware of, non-compliance is quite common in RCTs. So here in this example, I suggest that 50 or 25% of the participants are non-compliers. So that could be someone who actually doesn't turn up for a first consultation, if there are consultations, or who doesn't follow up treatment, depending on how you've defined that in your research protocol. So if there are non-compliers, we will still, in an ITT analysis, compare all those 200 who were originally included in the intervention arm with those in the control group. So we will get then an estimate not of the intervention received, but actually of the offer of intervention, as the effect of the intervention itself will be watered down if indeed there is an effect of the intervention. So the second approach, sorry, I just need to move this, there's this bar that's blocking my view. Maybe if I do it like that. Sorry about this. Okay, I'll just go on from here. So the second approach to analysis is a per protocol analysis. So we're talking about the same patients, participants, and the same data, but just a different way of analyzing the data, where we're comparing the intervention received versus the control. And the analysis is also carried out as participants are randomly allocated, but without non-compliers. So if all participants comply, then basically the per protocol analysis and the ITT analysis are identical. You get the same result. But if we have non-compliers in the trial, in this example 50, then those are not included in the analysis. So we will only be comparing the results for those in the intervention group who have actually complied with the treatment with those in the control group. And we may get an overestimation of the effect of the intervention then. So in the ITT analysis, we have a low risk of selection bias, but in the per protocol analysis, the risk of selection bias increases if there are non-compliers. So the ITT analysis is, as you probably know, very common and should also be, but the per protocol analysis is also quite common, and there are trials where only the per protocol analysis is reported and actually not the intention to treat analysis at all. A third approach to analysis is the as treated or on treatment, as it's sometimes referred to. In this case, we are comparing the intervention received versus the control, but this time we're ignoring random allocation. So if again all participants comply, then the result of the as treated analysis is the same as the intention to treat analysis. But if there are non-compliers, as in this examples, then those 50 participants who did not comply with the intervention are then actually moved to the control group. So that's why it ignores then random allocation. And this gives an overestimation of a risk of an overestimation of the treatment effect. And it introduces high risk of selection bias if there are non-compliers. This is less commonly reported, but it still exists. And I have even seen articles where they report only the as treated analysis, which is kind of puzzling to me, because that kind of negates the entire purpose of doing a random allocation of participants. So I think that these three approaches should be fairly familiar to you, the intention to treat, the per protocol, and the as treated. So that brings us to the complier average causal effect. And as you see, there are similarities to the per protocol analysis, as we will here only include those 150 participants who complied with the treatment. However, the difference is that in the control group, we will also include only those 150 participants who would have complied with the intervention if they had received the offer of treatment. And this may be a little bit puzzling. You might wonder how's that possible at all, but we'll get to that when we look at the example. So just to place case analysis into the wider context here. So the comparison here is the intervention received versus the control group participants who would receive the intervention if they had been offered it. And the analysis is also, as for per protocol, as randomly allocated without non-compliers, but in this case, also then with what we would call non-compliers in the control group. And if all comply, then the result of all these analyses are, of course, identical. But if there are non-compliers, my suggestion is that we might get a result that's closer to real-world clinical practice. The risk of selection bias is lower than with per protocol and as treated, but the use of case, as far as I know, is quite uncommon. So let's now look at a case analysis example. I think that will maybe clarify how this is possible, how we can even carry out such an analysis. So in this example, which is based on data that comes from my PhD project, but it's kind of been adjusted a little bit. We have a trial where we're testing an intervention for patients with moderate to severe depression, and this has been then measured using PHQ-9, the Patient Health Questionnaire. If you're not familiar with that, it's a brief instrument with only 9 questions to measure self-reported symptoms of depression. And it's been found to be comparable to established depression measures such as HADS. So in this case, we're doing an unequal ratio randomization with 1/3 receiving the intervention that is to be tested in addition to usual care, and comparing that to a group of 305 participants who receive usual care alone. So in this case, there are 59 non-compliers, so that gives a non-complier rate of 39%. And the outcome measure here is the PHQ-9 score at 6 months. PHQ-9 is a unidimensional instrument. So you get the total score, suggesting that it ranges from 0 to 27 points, and 10 points is kind of the cutoff for symptoms of moderate depression. If we carry out just a simple comparison between the two groups' scores at 6 months, we will, in this example, find that there is a mean difference of about 1.7 points between the two groups, a statistically significant result. So, kind of summarized, here's an overview with the number of participants in the groups, their respective mean PHQ-9 scores with the standard deviation, and you see the difference in means between the two and the p-value. The result of the per protocol analysis gives a score that's somewhat higher, 2.82, and as treated, approximately the same, just a tad higher. So what would the result be of a case analysis? So what do we know already? Okay, we know number of participants in the two groups, and we know their 6-month mean PHQ-9 score. And what we want to know is the difference in means between those in the intervention group who were compliers, who actually received the treatment, compared to those in the control group who would be compliers if they had received the offer of treatment. So the difference in means for compliers A and B. So we need the 6-month mean PHQ-9 scores for those two groups. So how can we find that? So what else do we have? Okay, we do know the number of compliers in the intervention group and non-compliers, and we know their respective mean 6-month PHQ-9 scores. So what are the number of compliers and non-compliers in the control group? Can we figure that out? We'll be making an assumption here. And first of all, we know that the number of non-compliers, 59 out of 152, that gives a proportion of about 39% non-compliers. And as this is a randomized controlled trial, we have made a random selection of participants. We will make the assumption that we will have the same non-complier rate in group B, in the control group, if they had received the offer of the intervention. So that would give 118 non-compliers in the control group if they had received the offer of the intervention. So that leaves a simple deduction of 118 from 305, which gives us the number of compliers in the control group if they would have received the offer of the intervention. The second assumption we're going to make is that the PHQ-9 scores in the non-complier group will be the same, will be comparable to the non-compliers in group A, as this is a randomized controlled trial. And we've made a random selection. So what we need then, what remains, is the mean PHQ-9 scores for the compliers in the control group, those who would be compliers. So we can then simply multiply the total number of participants in the control group with the mean score for those participants, and we do the same for those who are non-compliers in the control group. So we get two total scores, PHQ-9 scores for all participants and for those in the non-complier group, and that leaves a fairly simple mathematical equation where we just deduct 1,726 from 4,434. So we have the total score now for those in the control group who would be compliers if they had received the offer of treatment. So we can now simply divide that total score by the number of participants, and we get their mean PHQ-9 score at 6 months. So that leaves only deducting 1172 from 1448. So we get a difference in means of 2.76 points on the PHQ-9 score. So this is the difference in PHQ-9 mean score between those in the intervention group who received the intervention and those in the control group who would have received the intervention if they had been offered it. So if we go back to our table now, we can place the case analysis in between the intention to treat and the per protocol analysis, which is where it usually will end up. It's not far off from the per protocol analysis here, as you see, but it could be closer to the ITT analysis. That depends, of course, on the data that you get. So Hewitt, Torgerson, and Miles, they stated already in 2006 that although the ITT approach should remain the primary analysis, some form of case analysis should be performed as a secondary analysis instead of per protocol or on treatment analysis. So they're actually saying we shouldn't be carrying out per protocol analysis or on treatment analysis, but rather use some form of case analysis. And this was prior to the introduction of the TWIX or cohort multiple RCT design, as it's also referred to. So it's relevant to all sorts of trials. So let's take a little look at now, a brief look at a comparison of compliers and non-compliers. That may be relevant in your trials as well. As I mentioned, I was so fortunate to recruit participants from what was then called the South Yorkshire cohort, which is now the Yorkshire Health Study, and it now has over 73,000 participants. But back then in 2013, I think it was, there were 22,000 patients who had submitted their data and who had consented to be contacted again and for their data to be used to evaluate the effectiveness of interventions. Now, I could access their data, and based on their previous responses, I found that 5,740 indicated that they might have symptoms of depression. Either they said that they felt depressed or that they had some sort of symptom of depression. So what we did is we developed a new questionnaire, including the PHQ-9 instrument to measure their symptoms of depression, and we sent 5,740 questionnaires by mail to those cohort participants. My recommendation would be to do it digitally if you can. That's what we're planning for now. So out of these, about 38% responded, 2,200, and out of those 2,200, 566 fulfilled the inclusion criteria of the trial, which included, among other things, that they had to have symptoms of at least moderate depression. So those 566 patients were then divided into the two groups, the offer and no offer group. So an unequal randomization process. And you may do that, for example, in this case, the idea was that we would save some money, some of our budget by offering it to a smaller proportion, the intervention of to a smaller proportion of participants, and rather have a larger control group. But we knew that inclusion of non-acceptors in the analysis would water down an effect in an ITT analysis if there was indeed an effect of the intervention. And as you see, it's been termed here as offer and no offer group. So these were included in the trial, and then they were then offered the intervention. And we did not know beforehand whether they would accept the offer or not. And it was quite plausible that many of them would not. And indeed, only 40% accepted the offer of the intervention and had some treatment. And there are many reasons for that. For example, some of them did not think that they needed treatment, or they had some other health issues that they wanted to deal with primarily. So our question was, were offer group acceptors, those who complied with treatment, different to non-acceptors or non-compliers? So we compared their baseline characteristics and found that there were no statistically significant differences between the two subgroups in the offer group. So that meant that we felt more confident about carrying out the case analysis also when assessing our results. So the last point is a comparison of questionnaire responders and non-responders. So as you probably know, when you include participants in a trial, you will have X number of participants when you start out, and then some drop out along the way. So at the follow-up questionnaire at 6 months, or just above 80% of the participants submitted a follow-up questionnaire. And we were curious about how this was divided between the two groups and found quite a significant difference between the two, with 87% of no offer, those who had not been offered the intervention, who responded compared to 68% of those who were offered the intervention. So how come there was such a big difference? Well, we broke that down further into those who had taken up the offer, so that's the yes group, and those who did not take up the offer of treatment. And we found that those in the who took up the offer of treatment had a response rate comparable to those in the no offer group, whereas those who did not take up the offer of treatment, for them, just above half of them responded. And we don't know for certain the reasons why, but we have speculated about this, and we think that one possible reason may be that they didn't think that they actually were included in the trial. So this, I think, emphasizes the importance of clarity in the communication with the participants when they first join the trial. So we compared now the baseline characteristics for the offer and no offer group, responders and non-responders at 6 months. So those 4 groups, and tested all baseline characteristics. We did not find any differences in depression and anxiety scores, and nor did we find any other baseline characteristics that we considered likely to influence the outcomes. So again, we felt confident about proceeding with our case analysis. So the project was called the DEPSI project, the Depression in South Yorkshire, and the main outcome measure was, as I said, the PHQ-9 at 6 months. We included some of the baseline characteristics in our analysis, those that affected the 6-month results, which were the baseline depression scores, their use of antidepressants, long-standing conditions, gender, and socioeconomic status. And we found the ITT analysis showed the result of 1.4 point lower mean depression scores in favor of the offer group, whereas the case analysis, which was an instrumental variables analysis, showed a 2.6 point lower mean depression score. So a small to medium sized effect size were compared to the ITT analysis, which only resulted in a small effect size. So you see here how the effect of the intervention can be watered down in the ITT analysis. So finally, just a few words about my current research. Since, as I said, I've been at the University of Stavanger running a project which focuses on adolescent mental health. And since 2017, we've included 10 adolescents in our project. They're now co-researchers, and together we've developed a funding proposal. We've carried out some research as well, but we've developed a funding proposal to the Norwegian Research Council, asking, well, the total budget is around 2.4 million pounds, a 4-year project where we will be further developing an e-health intervention or portal developed by the Norwegian Directorate of Health, who are also partners in this application, and we will be using then the Twix design to run a trial to test the effectiveness of both the eHealth portal and also of youth leisure clubs for adolescents in general, and also for adolescents who have minority backgrounds. So I think that that's it. Yes. I will be sharing my presentation with you, so you'll find the references here, some very useful ones. You have the original article here from Claire Relton and her colleagues, published in 2010. There's also the concert extension for reporting RCTs using cohorts and routinely collected data, which I think you will find useful as well, and some other supporting articles.